Steakley. I'm the Director of Cameron County Substance Abuse Prevention Coalition.
I'm Karen Stigley. I'm the school director.
Norman Ox.
Justin, I'm in on the probation.
Crystal Rose Glover.
Marshall Farrell, our daughter's, before extension age is here.
Slaver Farrell.
Yeah.
Carolyn Motley, and I'm with the Chamber of Commerce.
Beverly Farrell.
Michael Ray, I'm the Director of the Health Department.
Travis Randall, Woodbury Lions Club.
John Bay Sanger, Woodbury Lions Club.
Barry Watts, I'm with the Woodbury Lions Club.
Bruce Stillman, UT Extension.
Keith Reddy with the Cannon Courier.
Officer Thompson, Woodbury Police Department. Officer Jimmy Hayes, Woodbury Police Department.
Sarah Murphy, Prevention Coalition for Success Director, the Coalition from Rutherford County. Casey Ball with the Prevention Coalition for Success as well.
Sarah Moore, Tennessee Child Care Resource and Referral Health Safety Wellbeing Coach.
Patrick Swanson, Tennessee National Guard, County Drug Task Force.
Lynn Aid, Congressman John Rose's office.
Eva Woodley, Mid-Cumberland Head Start.
Bobby Patterson, Cannon County Schools.
Kristen Jones, Family User Science Station. Johnny Black from Cannon County Schools.
Dees Oswald, National Guard.
Sam Finish, also with County Road.
I'm Trey Dees, Overdose Prevention Specialist with Williamson County Drug Coalition.
Thank you very much. Again, I appreciate all of you being here. We're going to go right into our program right now because I think that's probably the reason that most of you are here, and you won't be disappointed. I'd like to introduce again Trey Dees. He's with the Regional Overdose Prevention. He's the specialist on that. Come over from Williamson County. This is Trey's third visit, our second visit in 3 months. And Trey, I appreciate you making a turnaround trip over here because you were very much in demand for this. So we're going to turn this over to you.
All right. Thank you, Mr. Glenn. Can everybody see that all right? Yeah. I'm trying to make sure you can hear me all right too. So when I do, I'm a regional overdose prevention specialist. It's a contract with the state. What we do is we go to different places, whether it's law enforcement or places that may be high risk for opioid overdose. And we pass out what's called Naloxone, or Narcan, which you've probably seen in the news. The kits that we provide are for free. What you get inside is a kit that has 2 doses of Naloxone, a pair of gloves for obvious reasons, and then also a resource card for anybody who may be seeking treatment for any kind of substance use disorder. I love doing what I do, and a lot of it's just education. So a lot of this stuff may be new to some of you guys. Some of this may not be new at all. Some of this might be very, you might have a lot of experience with. But what the presentation is what we talked about, a little bit about opioids, what the epidemic is looking like, and how it's impacting Tennessee and your community specifically, the county of Cannon. Risk factors for opioid overdose. Talk about harm reduction, what that is. We talk about stigma and what that is, and how we're trying to reduce that. The addictive brain trauma, and recognizing an overdose, getting you to think of using a kit, why you would use it, how you would know to use one, and then we talk a little bit about compassion, fatigue, and burnout, which is just kind of something if you work with a lot of people, it's something that you may deal with. So what are opioids? A lot of these are you may recognize some very commonly prescribed opioids. From probably the midway to the top there, things that you may have in your medicine cabinet that you've been prescribed before, and then some of the street names of those that more users would use. And then down on the bottom, we've got fentanyl, which I'm sure you've seen a lot pop up in the news, and then buprenorphine. And those are just some more synthetic opioids. So the epidemic right now, more than 130 people in the U.S. die from opioid overdoses every day. In 2017, more people died from opioid overdoses than car accidents. The economic burden of prescription opioid misuse is $78.5 billion a year. And all these stats that we get are from the CDC. So in 2017, there were almost 7 million painkiller prescriptions in Tennessee, and that's more than one prescription for every man, woman, and child. In 2017, 1,268 people died from opioid overdose. The current death rate is 19.3 per 100,000 people. Now a lot of these numbers are from 2017. They're still crunching a lot of numbers from 2018, so these numbers are up from there. So these are all conservative numbers. And then from 2013 to 2017, certainly until to now, heroin deaths are increasing and fentanyl-related deaths are increasing. And that has to do with a lot of illegal drugs being cut with fentanyl because it's cheaper, and that's just what you're seeing a lot on the streets now. So this is Canyon County numbers from 2017. There were 4,441 people, or 1 in every 3, that received opioids for pain. 21,759 opioid prescriptions were filled in 2017. That's 1.5 prescriptions per every resident. Then there were 3 deaths in Canyon County due to opioid overdose, and 3 of those deaths were due to a heroin overdose. So if you look on the top, the first graph is the morphine milligram equivalent, which is what they use for how much opioids are being prescribed, how much being like the prescription amount, and then the dose. A lot of those are going down because of legislation, and that's good, but a lot of that also had people that were lawfully getting their medications or turning to other methods. Another unlawful way to get medications is to borrow medications from your neighbor. That's also an unlawful way to have medication. Then outpatient visit for non-fatal opioid overdoses, this is excluding heroin, actually spiked in 2015 and 2016 are also going up. So what causes overdoses? Opioids affect the regulation of breathing. They also block pain, that's why they're prescribed. They're great for that. That's what they're prescribed for. You take enough of them and then it slows the breathing. If you've ever taken any kind of opioid, you realize your heart rate goes down, everything kind of relaxes. It's very relaxed when you take a lot of them, and that's where the overdose comes into play. The person essentially stops breathing and suffocates. And the opioids fit on those receptors, and they bind to that. Synthetic drugs bind to that a lot stronger, like fentanyl, those kind of things. Some factors for opioid overdose. On the left, you may see somebody who might have substance use disorder. They could spend a period of time in jail, do a detox program or rehab, and then their tolerance being very low, they go back to using once they leave that program. On the right, you have things that can also affect people that don't have substance use disorder, people that are just taking prescriptions. They mix those prescriptions either knowingly or unknowingly with another suppressant like alcohol or a tranquilizer like a benzodiazepine, that's like Xanax, Ativan, and Valium. Also, a lot of elderly people have some trouble with opioids because a lot of them may not have the amount of capacity to know exactly what they're taking. A lot of older people may have 10 to 15 medications they're taking, and leave it out in the box, and they may not know exactly what everything is. A couple other things: if somebody has a history of overdose, history of addiction, maybe mental illness, or somebody who's on, and methadone is a maintenance medication for people coming off of opioids, coming off of heroin specifically. Somebody who's on a maintenance program like that also is at risk for overdose. What harm reduction is, it's a way of preventing disease and promoting health. It meets people where they are, because not everyone's ready or able to stop their drug use. So we try to use proven ways to limit deaths and to limit a lot of other issues. Those can be like MAT programs, that's medically assisted treatment, that's like the methadone, Suboxone programs. Naloxone is another way, and that's what we're getting today. There are a couple syringe exchanges in Tennessee. There is one in Nashville. We try to use a non-judgmental approach. We try to realize behavior change is an incremental process. We focus on enhancing quality of life or just giving people life in general. We try to realize there's social factors influencing vulnerability. It could be poverty, social inequality, discrimination, and trauma, especially childhood trauma. We try to empower those who use drugs to be the primary agents in reducing the harms of their drug use. Most people make more strong, sincere decisions when they're not being forced to do something. When it kind of manifests from within. So in the event of an overdose, you can practice harm reduction. You can prevent a death using naloxone, calling 911, give the victim they need, try to assess the needs, if they're willing to go to treatment or not. And then number 4, just having a conversation. That's a lot of what we're doing now. A lot of you guys are here. We're just trying to talk about it because this is one of those issues that's all over the place, but a lot of people don't want to talk about it. A lot of people may have family members that struggle, but you don't talk about it. So we're just having a conversation. One part of, we talk about stigma, and we think about opioid misuse, and we think low income. We have like a certain image in our mind that becomes like personal bias of like who's using these. Over 50% of opioid prescriptions are paid for with insurance. A lot of this is commercial insurance. People that have 40-hour work, who have 40-hour-a-week jobs that requires for them to get that commercial insurance through their company. So it's not just people getting stuff off the street. You know, it's people that are in cubicles next to you that work in the same office. I mean, it's just part of it. And in 2017, the average number of pills prescribed after surgery was 82. A lot of these numbers are down. There's new legislation where people can't just leave the hospital with a bag full of pills and just be like, oh, on your way, hope you feel better. There's also different ways, like, you know, getting those refills is a lot more difficult. 12% of surgical patients report later opioid dependence or addiction. Dependence and addiction are two different things. Dependence happens just where you physically need opioids to feel a certain way. If you take one opioid pain pill a day for a month, you're going to want to take more by the end of that month because it's not going to have the same effect. And a lot of people get dependence, honestly. Addiction is a whole different thing. Addiction is more the compulsive behavior, those kind of things. But 66% of surgeons report feeling pressure to prescribe more pills than necessary. So with reducing stigma, we try to do away with labels. We use person-first language. We use person with substance use disorder, not drug addict or alcoholic or whatever in that category. We realize that drug use falls on the continuum. Relapse doesn't equal moral failure. A lot of people make mistakes when they're trying to get clean and change their life. 40 to 60% will relapse at least once. We try to be aware of unintentional personal bias. We try to recognize addiction is often connected to trauma, especially childhood trauma. Addiction is a chronic disease that changes brain structure and function. The pleasure principle of addiction is that when people have substance use disorder, when they go back to using, they don't think about the rough times when they lose a car, or lose a job, or lose family members, get their kids taken away. They typically go back to those kind of scars in their mind of when things worked, when they're riding around in somebody's drop top having a really good time. That's kind of where they want to get back to. That's just that memory. We call that, a lot of people call that triggers, we call it cravings, those kind of things. It's conditioned response. I'm not sure, some of you, just from hearing what your job description is, a lot of you guys are going to be familiar with ACEs, but what they are is adverse childhood experiences. It's a test that you have. There's a list of ACEs on the bottom there. It's a test where you would go through, did you experience this? And with every one of those, you would mark a yes. They count those up at the end of it, and then they kind of get a result. Once you start getting 4 or more ACEs, there's a lot of other factors. There's a lot of things that can take place. A lot of potential for misusing drugs and alcohol and other health-related issues. 28% of adults report physical abuse, and 21% report sexual abuse. 40% of adults reported 2 or more ACEs, 12.5% experienced 4 or more. Individuals with 5 or more ACEs were 7 to 10 times more likely to use illicit drugs. And individuals with 6 or more are 46 times more likely to be IV drug abusers. So now we're going into recognizing an overdose. So signs that someone may be over-medicated or high, pupils will be very small. The black part of the eye will get very small, kind of pinpointed. They may not nod out, they can scratch a lot, they have that itching sensation. Speech could be slurred, they may be out of it, will respond to outside stimulus, like snapping at somebody, calling their name, shaking them, they'll respond to that. Overdose signs would include loss of consciousness, unresponsive to that same stimulus. Breathing can be very slow, shallow, erratic, or stopped. Choking sounds, which snore like gurgling noises. Vomiting, body being limp, face pale and clammy, fingernails blue or purplish black. Pulse or heartbeat could be slow, erratic, or not there at all. Overdoses can also happen slowly over the course of several hours. It's not always an immediate thing, depending on what substance the person is using. So there's some myths about reversing overdoses. A lot of these we can thank media for. Putting somebody into a cold bath or shower like an ice bath, what that can do is send their body into shock, but also they can drown in that water. Injecting that person with something else, like if they were taking opioid, it's a downer, they give them something that's more of a stimulant. That's not going to help. That's going to cause more problems than what you're dealing with already. Trying to make the person vomit or giving them something to drink, like when you're had too much to drink, you want to eat something, it's not the same thing. They also choke on that, especially if they're already having trouble breathing. And then giving that person over-the-counter drugs like vitamins to detox them or no-dose, which is like a caffeine supplement. Those things are not going to reverse an overdose. So what naloxone is, we talked in the beginning of that slide about the receptors. There's opioids binding to those receptors. What naloxone does is it comes in and kicks those opioids off the receptors and binds to them stronger. So essentially, you're taking the opioids out of that person's system, at least in their brain. They still have the opioids in their system, but it's not affecting the center that's affecting that breathing. 30 to 90 minutes. And one thing about it, if somebody has withdrawal symptoms, typically when they don't use opioids, they'll go right into withdrawals. That's a big problem that a lot of the first responders and police officers are running into because they hit somebody with Narcan and they come out pretty upset. Because a lot of them don't really know what's going on. And then they're going to go back into that musculoskeletal pain, those physiological feelings of pain that are associated with withdrawals. So there's a couple variations. The third one from the left is the one you didn't get today, the Narcan, the nasal spray. It's arguably the easiest one to use and easiest one to carry around. The most common, the cheapest one to get at a pharmacy is the one on the very right, the atomizer. It's also a nasal spray, but as you can see, it's a lot of different parts. Then there's intramuscular, which are on the left. The one on the very left is kind of like insulin, where you could actually draw it from a vial and then inject to somebody. And then the next one over is actually more like an EpiPen, which a lot of you, I'm sure, are familiar with. You hit somebody in the outer eye. With the intramuscular, it's always outer eye, the biggest part of the biggest muscle. But those are also very expensive, and Narcan is what we do give out. That's what we give to first responders and civilians alike. So there's no evidence giving people naloxone makes them more likely to use it. Naloxone keeps people alive. Going through withdrawals is a painful and unpleasant experience. The research has shown us that people who are injection drug users, that they're trained on naloxone, they actually reduce use over time, and they have that overdose response behavior. So there's a standing order in Tennessee right now that anyone, you, me, anybody in this room can go to the pharmacy right now and buy naloxone. It is expensive. Insurance doesn't cover a lot of it. There's also policy in place if somebody has a high dose of opioid that they're being prescribed, the pharmacist will recommend that they get naloxone, but a lot of times they're like, okay, add it to my bill, and then the bill becomes $150, and they say, well, don't worry about it. I won't worry about it. So that's one reason I like doing what I do, because it gives people that opportunity to have that case. Tennessee Addiction Treatment Act is that any person seeking medical attention for themselves or someone else after an overdose has immunity from prosecution for a drug violation on the person's first overdose. So that's hopefully in place to keep people from kicking someone out the door at an ER if there's something goes wrong. The Good Samaritan Act is more of a law for people administering naloxone, also CPR. It's a similar law. So any person who administers naloxone in good faith to someone experiencing an opioid overdose, who has evidence by certificate, which you guys will get at the end of this, that they're also immune from any kind of prosecution if it didn't work or something. So responding to the overdose, the biggest thing, and it's not on any of these slides, is just try to remain as calm as you can. It's one thing to look at slides and say, oh, step one, step two, and then in the heat of the moment, it's a little bit different. But try to maintain responsiveness, call the person's name, shake the person. Utilize the sternum rub, which maybe some of you guys are familiar with. The sternum rub is where you can take this part of your fist and rub them here. If you rub yourself there, you can tell it doesn't hurt like crazy, but it'll get your attention. It's a good stimulus to see if somebody's going to be responsive. And if that person doesn't respond to that, you move to step two. So naloxone needs to be stored at room temperature, just an FYI. You don't want to freeze it, you want to protect it from light. So if you leave it in your car for several years. It also has an expiration date, which is on the box, and if you guys happen to have a unit that goes to an expiration date, you can always give me a call and I will drive out to you and exchange it. And also step two would be administering naloxone. Step three is calling 911. Those are interchangeable. You can be calling 911 as you're doing this. So you don't need to say, oh, I need to do something myself first, and then I'll call 911 when I'm done with that. No. Trust the ones who know what they're doing. So peel back the pack and remove the device. Hold the device with your thumb on the bottom of the plunger and 2 fingers on the nozzle. Place and hold the tip of the nozzle in either nostril until your fingers touch the bottom of the patient's nose. And basically, that's a lot of words to say. Put it as far in as you can, because that person, remember, they're not breathing. They're having trouble breathing. They're going to need help to get that in there. They're not going to sniff it like phlegm is, where you're consciously saying, okay, I can get this in there. You need to kind of help them do that. Then press the plunger firmly, release the dose into the patient's nose. Peel, place, and press method. Then calling 911, staying with the person until emergency medical services arrive. Tell 911 the address or location where to find the person, if breathing is slowed or stopped, if you gave naloxone or how much, and what medications or substances the person's took, if you know. And if a lot of this seems like I don't think I would ever use this, it seems like something that's very silly to have. A really good friend of mine, she's kind of like my sister, a good family friend of hers, who is a banker downtown Nashville, mowed his lawn Saturday, passed out, neighbor found him, heroin overdose. They would have never suspected that. You know, he's the kind of guy, poster child for just a good guy, and you just wouldn't know. That's the thing about drugs, that you just don't know. And with opioids too, people are prescribed those and they can be accidental overdoses. That's part of that stigma, you know. My bias of him was like, oh, he'd never do that. But there he was on his front lawn Saturday. So this is really, if 911 operator is telling you to do CPR, that's great. If you're trained on CPR, then use CPR. If you're not trained on CPR, you can do a lot of damage to somebody, banging on their chest and stuff, and you can cause more problems than what you're already dealing with at the time. So you know, if 911 tells you to do it, yes, it may be necessary, but if you're not, don't, you know, there's just a lot of cases of people breaking ribs and things, just kind of in that emergency mode, in that fight or flight, just trying to get somebody to start breathing. So the recovery position, which Will actually demonstrated for us the last time we did this, is on the side, not on the back, not on your stomach. Tilt the head back, lift the chin to open the airway, turn to one side, place hand against chin, bend knee against the floor, tilt the head back, check for breathing, then call emergency and wait till it arrives. So that's the recovery position. That's the easiest way for them to get breathing again. So stay and watch the individual. They may have no memory of overdosing. Try to comfort the individual as much as you can. Just remember that naloxone will trigger withdrawal symptoms if they are experiencing those. Help the individual to remain calm. Discourage using opioids for at least 2 hours, because again, there's withdrawal symptoms. They don't feel like they have any opioids in their system. They're breathing again. Their first thought is like, use more. And that's not even going to work. The naloxone attached to the receptors, it's going to be a waste for them anyway, but also once that naloxone wears off, it can send them back into an overdose. So yeah, prevent the opioid overdose by telling them not to use, and then try to encourage them to receive care for the opioid withdrawals. Then inform the paramedics if naloxone is administered, and then what substances you know, if you know. So remember, naloxone will last 30 to 90 minutes. Opioids can stay in a person's system for hours. The second overdose may occur, especially if the individual takes more opioids. Naloxone may cause an individual to experience some of the following withdrawal symptoms. They can be violent or irrational. They can have projectile vomit, have a cardiovascular event if they do have a pre-existing condition, and experience that musculoskeletal pain we talked about that are associated with withdrawals. So really quick about compassion fatigue, and if you work with people, this is something that maybe your company talks about. Compassion fatigue is a secondary traumatization. It's emotional residue restrained exposure to working with those suffering from the consequences of traumatic events. It's a rapid onset deal. Burnout is a cumulative process, emotional exhaustion associated with increased workload or stress, and it emerges over time. Some symptoms are emotional, physical, and/or mental exhaustion, reduced sense of personal accomplishment or meaning in work, decreased interaction with others, and isolation. So things to do in these cases: find someone to talk to, understand the pain you feel is normal, exercise and eat properly, get enough sleep, take some time off, journaling can help, develop healthy boundaries at work and at home. And don't fall into the habit of complaining with your colleagues, don't try to work harder and longer, don't self-medicate, and don't neglect your own needs and interests. So these are also conservative numbers. We're looking at more like 45,000 units that we've distributed since October 2017, and the saved is actually closer to 4,000. On the bottom there's a link, and that link can be found on the state website. The state website has this, well, it has a similar presentation than this. It also has a map of all the people that do what I do and what areas, what counties they cover. But that form is actually an overdose reversal form. So if you were to use one, I would encourage you to go to the site and say, hey, I had to use this. Was the overdose reversal successful or not? Because this helps us to stay funded to keep making sure our first responders and people like you can have these things at no cost. Police officers use a different form that we look at, and they're the most diligent because it's part of their job of reporting. But a lot of these numbers are conservative because a lot of people they're not going to report that they have an overdose or that they have a friend that overdoses. So that's one thing we do try to encourage. If it's anonymous, we just want to get the data so we know if we're helping or not. All right, so this is a really quick training assessment. What forms of naloxone are available? Yes. Second dose of naloxone may be necessary before EMS arrival. Yes. You should give the naloxone and leave the patient alone. When administering intermuscular naloxone, that's like the EpiPen or the syringe, where's the best location to give the injection? How long does naloxone last? Naloxone is an addictive substance. How do you determine when someone is overdosing? A little reading on it. All the above, that's right. Call 911 as soon as you suspect an overdose. Chest compression or CPR may be necessary. It's the longest reading one, the Good Samaritan law. Remember, this is the one that's for the person administering naloxone.
B.
It's A, it protects you from civil liability for administering naloxone to a person believed to be experiencing an overdose. The Good Samaritan law is for the person administering the help. Good Samaritan. All right, so these numbers have changed a little bit. Some insurances have dropped the coverage for naloxone, but these are some of the prices that you'll see at some places where you go. But with this, it's all going to be free. But if you did want to get one, you can always go to the pharmacist and just say, hey, how much would this do? Just to see. And these are the different regions that we cover up. There's 13 regions. There's 20 of us across the state that do this. And really appreciate you guys coming out and supporting us. And so I guess at the end of the meeting, what we'll do, I've got certificates. I also have the kits. You guys also have the evaluation forms. If you don't mind just kind of filling those out and then dropping those when you get a kit. That just lets us know how our presentation is, what we can do better to improve everything, feel free to be honest if you like on there. And then after the meeting, we'll get you guys kits and we'll get to go. So, thank you.
Thank you, Trey, for that wonderful presentation. We certainly appreciate you coming back and presenting this again. We've had good response from the first meeting we had, and I think you can see by the attendance that it's well appreciated. Before we go any further, if you'll look around, we notice we have several members of the Tennessee National Guard Task Force. Without these people, we wouldn't be able to present what we present to you today, because they have done a fantastic job of leading us to where we are right now with this coalition. So they are very, very much appreciated. I think we have one member in the hospital.
He's up. Yeah, he's out.
Oh, he's out. Okay, good. Good. Next, has everyone signed in on the sign-in sheet as you come in? If you haven't, I'd like to ask you, please do so. Next up, we have Mrs. Steakley would like to address the coalition.
I want to thank y'all for allowing me for the board. We want to see the coalition up and running. It's a pleasure watching with the other members. You see happen while we get this started. I'm excited about the work with the community and the representatives and just the exciting things, the opportunities we have before us. I do want to resign at this time because I want to become the coalition's event coordinator. Because I am retired, I have no time to do something like that and somebody else might. So, thank you, and
I know, I personally know how dedicated Ms. Steakley is to the well-being of our community and its citizens. I want to thank her for the good work that she's done thus far to get us up and going and serving on the board. And I'm extremely appreciative of the good job that she's going to do in the future. So we won't miss you. We'll still use you. With that, from the revised agenda that you have got on the email and we had some back on the table there, we're going to